Hello everyone, this is Brainless Medico and I am Dr. Manoj, and today we are going to learn an important topic in rheumatology, that is systemic lupus erythematosus. So let's dig into it. Systemic lupus erythematosus definition goes like this. It's a chronic autoimmune disease in which the body forms autoantibody against nuclear components causing multisystem inflammation. So it is on superficially, if you come to know what is SLE means, it's an autoimmune disease, example of autoimmune disease. So in this video, we will learn subtopics like this: epidemiology, then we will learn pathogenesis, then we'll go into risk factors, then we'll go into clinical features, which also includes criteria of clinical features and even diagnostic. Then we'll go with the treatment part. Okay, so let's learn it easily. Coming to epidemiology, it will be seen in 20 to 30 years of that year. It is most commonly seen and it is gender biased, like females. Yeah, females. Then coming to pathogenesis, you need to remember 5 mainly pathogenesis. It goes like this: loss of immune tolerance, formation of autoantibodies. We discussed about this in definition. Then coming to this AN and anti-dsDNA, we will learn this detailedly in the criteria. Then coming to immune, third point, immune complex depositions, complement activation. Then coming to, at last it leads to multiple organ damage. So what happens? First, loss of immune tolerance will be seen, which leads to formation of autoantibodies, which leads to immune complex deposition, which leads to complement activation, then which finally causes multi-organ damage. So it is a good example of type 3 hypersensitivity reaction. Then coming to risk factors, mainly you need to remember 4 risk factors with the one example so that you can impress the examiner. So in genetics, remember TREX1. No need to go into the detail of the genetic, that what it defines and all. Just remember TREX. It's a like example of a dinosaur name. TREX. Then chromosomal, you need to remember Klinefelter syndrome. We will learn this Klinefelter syndrome separately in our chromosomal abnormality playlist. You can go and watch it. Then coming to infections, Epstein-Barr virus, it is also one of the important topic in medicine. So we will learn this detailedly in the infection playlist. Then coming to toxins, UV rays and silicosis. So there are 4 risk factors: genetics, chromosomal, then coming to infection, at last toxins. And we have specific set of clinical features you need to understand. We have 11 clinical criteria. There are 2 criteria. One is SLIC and one more is ULAR. There is nothing more difference between both the guidelines. Only minor changes are there. We will look into it at the last. So coming to 11 criteria, under skin and mucosa, we have 3 criteria. Malar rash, which will be like butterfly shaped. Like I'm bad at diagram. So it's a butterfly shape. I think you know how butterfly looks. Then discoid rash, oral or nasal ulcers. We will make separate video about this clinical feature because it is very important topic. Like for theory exam, I think this is sufficient. For entrance purpose, I'll make a separate video on this individual about what is the most common and what is the important diagnostic feature and all. So that I will upload it soon. No need to worry. Then coming to musculoskeletal, symmetrical, non-erosive. Non-erosive, you need to remember arthritis because it is not erosive, so it is reversible, called as Jacob's arthropathy. Okay. Then coming to renal, it leads to lupus nephritis. It's a 3 marker. We'll make a separate shorts or some small video about this lupus nephritis soon. Then coming to next in the renal part, we have proteinuria or hematuria. Okay. And then in CNS, like it causes headache and all. Most commonly, you can remember seizures or even convulsions or neuropsychiatric features like psychosis. Coming to hematological features, we have hemolytic anemia, leukopenia, then coagulopathy. It's like a normal references what we learn in our hematology. I will detailedly look into this. We will detailedly look into this hemolytic anemia in our and this leukopenia and coagulopathy in our hematology section. You can go and watch. Then coming to diagnostic purpose, we have 6 immunological criteria, where mainly we look into 3 autoantibodies, then one is complement system related, and then other two are there. So autoantibody ANA, highly sensitive. Then coming to anti-dsDNA, disease activity marker. Then coming to anti-Smith, highly specific. So this is the one we usually prefer. Then complementary, we usually see C3 and it will be usually low in the level. Then coming to others, direct Coombs test, which is not at all useful. You will learn why it is not at all useful now. And APLA, both sensitive and specific, 50 to 60%, but we prefer anti-Smith autoantibody for our regular purpose. Then as I said above, we have two criteria, SLIC criteria, then one more is Euler score. What is the basic difference of these two are? In SLICs, we are going to see more than or equal to 4, at least one of each to confirm. I mean, at least one of each means we studied clinical features and one more is immunological, at least one of them, and it should be total of 4. Okay, this is what in SLIC's criteria it defines. But whereas in Euler there are some minor differences. As I said, Euler we are going to see total more than 10 should be the score to confirm SLE accurately. Then what is the another difference? In ANA we have specifically more than or equal to 1:80 is the entry criteria. Then coming to excluded DCT, as I said, it is nowhere now very useful because it is neither specific or sensitive. And we as I said, in general features we added fever for diagnosis. So the difference between the regular criteria and the Euler's criteria is it will, so after removing the DCT it will become 5 immunological criteria, then adding fever with the regular 11 clinical criteria, so it becomes 12. So I think there is no doubt here. If you have doubt, you can just go back and watch the video again, small part. Okay, then coming to treatment, it's a huge concept. Let's make it simple. Like as we get this question for 10 marker or 5 marker, rarely we get a 10 marker from rheumat in final year, but if we get a 5 marker, then its treatment part will be max to the max 1 mark. So let's focus what we can write so that we can concise and we can revise. So we divide treatment into 3 parts: generally, then mild disease, then moderate to severe. So how you are going to handle the patient when the patient comes? First you need to give NSAIDs, hydroxychloroquine. If the patient is like severe or like moderate, then you need to go with the corticosteroids. And the other thing is immunosuppressants. These are the important drugs which play important role. Examples of this immunosuppressants: azathioprine, just read it, mofetil, enough, mofetil, right? If you want me to read, mycophenolate, mofetil, but if you want to remember, just remember mofetil, mofetil, then cyclophosphamide. This is given in severe nephritis. That lupus nephritis we discussed, I'll make a short video. I said that for that treatment specifically we give cyclophosphamide. Then while discharging the patient, you need to say avoid sunlight. So that to avoid sunlight, what you have to do, you have to apply well protective sunscreen, then vaccinations for the infection, then regular monitoring. You need to monitor if you're finding any difficulty or any rash again, recurrence, so you have to come back and get the treatment. So I think it was a bit lengthy video, but it would have been like useful. So let's revise it quickly. It's a chronic autoimmune disease. Autoantibodies will be produced against nuclear components causing multisystem inflammation. And what is the age group? 20 to 30, male preponderance. Then coming to pathogenesis, we learned 5 points. Loss of immune tolerance, autoantibody will be produced, immune complex deposition happens, complementary system activation, then multi-organ damage will be seen. It's a good example of type 3 hypersensitivity reaction. Then coming to risk factors, 4 you need to remember. I said dinosaur treks, something like that. Then Klinefelter syndrome, then Epstein-Barr virus, then sunscreen you need to apply because UV rays and silicosis is the risk factor. Then coming to criterias, we have to SLIC or EULAR. We are from 2019 we are preferring EULAR, so you need to remember more detail about EULAR. And the 11 criteria which goes with the skin and mucosa, musculoskeletal, even renal. This is the lupus nephritis, you prefer cyclophosphamide for the treatment. Then we have CNS features. Here we are adding fever also, so that EULAR 2019 score will be updated. So that hematological. Then coming to immunological criteria, we have 6 criteria, but according to EULAR we removed DCT, so at last it will be 5. So we have to SLIC criteria, EULAR score. No need to remember the full form of SLIC, what is SLIC, what is EULAR. Just remember the points. What is the importance of the EULAR score? Total it should be at least more than 10, so that it confirms SLE accurately. Then ANA should be at least 1:80, more than 1:80 or equal to, so that it should enter the criteria. Then exclude DCT, fever for diagnosis, which leads to, like, after removing of DCT it becomes 5 immunological and adding of fever will become 12 clinical parameters. So what is the treatment? Mild or moderate. In mild we give NSAIDs, then hydroxychloroquine. In moderate we give corticosteroids, immunosuppressants. I said don't forget mofetil, cyclophosphamide, azathioprine. And while discharging, avoid sunlight. To avoid sunlight, what we have to do? We have to apply sunscreen, and for infections we have to give vaccinations, then regular monitoring. I hope you people enjoyed the video. That's all for the video. Subscribe to the channel. Thank you.